And the reason why she lost was a reason that constantly ends up like, this is something my philosophy, is because the opposing side said it was too expensive. And now we have treat all. And so whenever I think about that debate, I think, whoa, Diane Havlir must feel very vindicated about that debate at the Bangkok Symposium all those years ago. Well, fortunately, we have a number of topics that we'll be able to cover on ending AIDS in the region. And what we'd like to do is to ask you to begin thinking of questions that you have for our speakers, because as I said, each of them will speak for about 15 minutes, and then we've left about 20 minutes or so for us to have a group discussion. And so please be prepared to engage. We have microphones here. I'll be calling on people with questions, but also we'll be having a conversation here on stage between ourselves. But I don't think it's as much fun if it's just us talking as talking with you. And I brought up the debate because there is no debate this year. So we don't have quite as much of a chance to have that kind of a back and forth conversation with the audience unless we have this sort of panel discussion. So our first speaker for today is Mr. Steve Kraus, and his slides are, well, am I on? Oh my goodness. Hello. Where's the hello? So Mr. Steve Kraus is going to come up and speak, and many of you know who he is. You can see his title there, the director of the UNAIDS Regional Support Team. But under his tenure, under his leadership, so many things have happened through UNAIDS and here in the Asia Pacific region. We've had the 3 zeros. We have 90-90-90. And some of you may know that there was a very interesting report that came out, I think it was last year, called Under the Radar, that focused on young people living with HIV. And this is a topic that's going to come up throughout the Bangkok Symposium, but it was really under the leadership of UNAIDS, UNICEF, and their partners that this report came out and decided to focus just on young people living with HIV here in the Asia Pacific. And key affected populations have also been a huge priority for him and his team. So I'm very pleased to invite Steve to give us his presentation.
Thank you very much, Annette. It's great to be here. As Dr. Prapad mentioned in his opening comments this morning, it's a particular privilege because we're celebrating the 20th anniversary of HIV-NAT, and what an honor it is to be, as UNAIDS, a partner with the Thai Red Cross and the many other partners in this event. I would like to just also comment to all of you who are Thai. I want to just communicate the condolences of the international community, of the UN, of all of us who have the opportunity and the grace of being and living in the Royal Kingdom of Thailand on the passing of His Majesty Bhumipol Adulyadej, a wonderful king. I think that many of us feel not only sadness in his passing, but we also feel like we lost our king as well. And so to all of you who are Thai, I want to voice our condolences, and to our international family members, particularly those of us who have had the opportunity of being in Thailand for several years, our king as well. It is traditional that when you have an opportunity to speak in a public forum that you offer your disclaimer right up front. Now, I usually don't do that because I think people assume that if you're from the United Nations system, there should be no disclaimers. But I'm going to tell you straight up front, I do have one disclaimer, and in fact, I don't think I've done this publicly, so let me say that my disclaimer is that I am in love with Dr. Prapan. And so when Dr. Prapan extends an invitation, I just simply cannot say no. I've been in love with Dr. Prapan for almost 30 years. He was one of the very first people I met when I came to Thailand in 1989 to work on the HIV/AIDS response. And I have learned to love the man again and again and again. So to all of you, particularly for young Thai health professionals who might be here with us today and are looking for mentors, I don't think you could go wrong by following and listening the footsteps of Dr. Prapan Panupak. He is truly a clinician, he is truly a researcher, and he's a real true social activist and advocate. So to all of you, thank you. I would like, in my 15 minutes, just to go through, I have 18 slides, and I won't spend equal time with them all, but I would like to, I think there's like about 7 or 8 slides that are on epidemiology, about Asia and the Pacific on HIV, and then from that, I'd like to just toss out a few slides, and I'm going to repeat during the 15 minutes 5 different recommendations for policies that would move us forward to ending AIDS by 2030. So let me begin. I think that all of us must know in this room that every 5 years the international community gathers together in New York and they create a high-level political decision on where the epidemic is and where they would like to see countries move over the next 5 years. They did that in June of this year, of the last year, June 2016. 193 member states agreed that we can end AIDS by 2030, but we have to do really robust activities between now and 2020 to achieve our goal. Now, just as you would guess, 193 member states, that includes every country that is represented in this room. So it is important, I think, politically to understand that what we're talking about here has already been endorsed by our governments, by your governments, that this is the way to move forward. Now, they also committed themselves to some very ambitious targets. So you see in that first column by 2020 and in the second column by 2030 that we will reduce by 2020 fewer than 500,000 new infections, fewer than 500,000 AIDS-related deaths, and zero discrimination. And then they bring that out to the year 2030. Now, what is unique about the political declaration that took place in New York in June of this past year, it's like 6 or 7 months ago, is for the first time they had regional targets. We've had high-level meetings on UNGAS, the United Nations General Assembly Special Session on AIDS, in 2001, a high-level meeting in 2006, another high-level meeting in 2011, and the most recent one, 2016. This was the first time at the global level that member states agreed to regional targets. Usually they agree to global targets, but not global. And so for the first time in Asia and the Pacific, we have a target that by the end of December 2020, we will have no more than 90,000 new infections taking place in our region. We will have 4.2 million people on treatment, and we will have zero discrimination. So those 3 slides are what member states have agreed to at the highest levels of their governments. So how well are we doing right now? On the areas of prevention, this gap that you see on the right-hand side, that yellow or orange line that you see, and the green circle, that is where we have committed ourselves as member states to be by the year 2020. 90,000 new infections. Unfortunately, for the last 5, 6, 7, 8, 9, 10, almost 12 years, we have seen no decline in the numbers of new infections in our region. We have stagnated in Asia and the Pacific around 300,000 new infections every year. About a third of those infections are among women and girls. On treatment, we're much better. Our region has some of the lowest treatment coverage in the world, but in our region we have been able to step up treatment coverage by about 15% every year for the last 3 years. If we keep on that pace, we should be able to get 4.2 million people on treatment by 2020. But anybody who's been involved in any public health program will know that it's always the last 20% that is the most difficult, and it's the last 10% that are the most difficult. And so, in a sense, those who have been easy to reach, we've been able to get on treatment, and the larger challenge now is, will we be able to keep up that pace and ensure that 4.2 million people are on treatment? As it stands today, we have over 5 million people living with HIV in our region and only 2 million people on treatment. That means 2 out of 5 are receiving treatment, 3 out of 5 are not benefiting from the benefits of ARVs and the social and medical progress that we've made in the last 20 years. It's astounding, but even with the situation today, 60% of those who need treatment today are still not receiving it.
And then in terms of discrimination, we used to talk a lot about universal access. In fact, what we really have when it comes to the legal environment in our region are universal obstacles to reach and to work with real people in their real lives, the way they live their lives, because of the legal environment. Most countries in our region continue to criminalize criminalize sex work. Half of the countries continue to criminalize same-sex behavior, many of which are carryovers from their colonial past. We continue to incarcerate people who use drugs, knowing very well that today's internationally agreed principles are that drug use and problematic drug use and abuse is much more of a health issue than it is a legal law and order issue. And we know that when we have good public health programs, the law and the law follows in terms of reducing crime results as the result of good public health interventions. We have half of our countries still imposing the drug penalties, and several countries have in the past 18 months reinstituted the death penalty for drug use. And then 10 countries continue to impose what we know that does not work is immigration and short-term travel restrictions for people living with HIV. So not universal access, but rather universal obstacles when it comes to the legal environment. Now, I think many of you may have seen this slide, but if you look on the left-hand side, you see the 12 countries that account for more than 90% of all the infections in our region. And if you look at those list of 12 countries, 3 of them are highlighted in yellow: Indonesia, Pakistan, and the Philippines. All 3 of those countries, HIV infection has increased more than 20% in the last year, in the last 2 years, and in the last 3 years. This is a problem because every time we've made success in one country, another country comes up as a leading source of new infections. Now, the red ribbons indicate that while no country in our region has more than has no more than 1% of the general population living with HIV, the highest generalized adult prevalence rates in our regions are Thailand and Papua New Guinea, and both of them are less than 1%. It's around 0.8%. So every country in our region, every country, you can say the epidemic is in among key populations. And particularly it's men who have sex with men, people who inject drugs, female sex workers, and transgender populations. And wherever you see the red ribbon there, those prevalence rates among those key populations are over 5%. And it is also true that across our region, those key populations tend to be highest in their aggregated numbers in large urban centers. So for example, people who inject drugs, nationwide prevalence in Indonesia is 29%, but those individuals who inject drugs and they happen to live in Jakarta, it's actually around 44%. So cities after cities after cities are very important in terms of where the epidemic is and where we need to direct our efforts. Now, I wanted to just introduce this because one of the policy recommendations that I cannot help but to bring up is that we need governments and civil society and all of us to embrace the concept of harm reduction in the context of drug use. More than 90% of people who use drugs have no problematic drug use. About 10% who do use drugs will have problematic drug use and will need to address issues of addiction. But whoever is using drugs, they need access to clean needles and syringes. And yet if you look at the countries in our region, we have come a long way, but we have so far to travel when it comes to more needles and syringes for those who use drugs. And you see that only a handful of countries, one of the reasons why Cambodia can talk about the highest coverage rate for treatment, and now instead of 23,000 new infections a year, they're down to less than 700, is because they haven't implemented an aggressive harm reduction strategy for those who use drugs. It is not true for other countries, and you can see the countries in red. Now, let me just offer, I know a lot of smart people have spoken already today about the need to expand testing. Here you see that among key populations, those same key populations we've just talked about, In every case, less than half of them know their HIV status. This is, have you been tested in the last year? So look at that. We know where the epidemic is. We know the key populations are crucial. We know working with cities is essential. And yet we're not able to help key populations know their HIV status. Now, let me suggest this, and this is what I thought was captured so well by Dr. Prapan and Dr. Nitya and others this morning. If we keep doing the same thing in Asia and the Pacific, can we expect different results? Here's what we've been able to do over the last 6 years regarding people knowing their HIV status. The point I'd like to suggest here is that unless we're willing to innovate and to try new things, we're not going to see a change. And the data would indicate that. If we just do status quo, status quo, status quo, and say, well, if you want to get tested for HIV, you can go down to a government clinic or a community center, and the government officials there will take your blood, and you can get your test results in 48 to 72 hours. That's what we've been doing. But if we innovate, it's our only real way to meet our targets by 2020. So let me just share this slide. That does not mean that that we don't have examples in our region. We have 5 out of our 12 priority countries that are actually innovating with community-based testing. Countries such as China, India, Philippines, Thailand, Vietnam, Cambodia, all of these are innovating with new ways of doing community-based testing. But perhaps a key word here is piloted. And somehow we have to go from just piloting innovative boutique kind of things into nationwide policies and practices that really are game changers. Status quo isn't going to get us to where we want to be. I wanted to use this example from Thanh Hoa province in Vietnam. The red pillar there is an example that when Vietnam introduced community-based testing and counseling, i.e. allowing testing to take place in the community, by the community, they were able to identify those who are living with HIV at a much higher rate than those at the health centers. So again, international best practice from a country as Vietnam and Thanh Hoa as the province, we know, and there's other countries, other regions, other provinces that do the same thing. But we have evidence in our region that when we do this, it works. It makes a difference. So let's do it. If we are on the fast track, and if we want to hit the 90-90-90, we know what to do. Now, self-testing should be offered as an additional approach to HIV testing services. This is a WHO recommendation. I'm always humored a bit when I meet with policymakers, oftentimes government officials, who say, well, we're waiting for the WHO recommendation before we can change our ARV counts or our policies on this or that. WHO has been extremely clear. And they have said HIV self-testing, so this is home-based testing, should be offered as an additional approach to HIV testing services. So again, we have the international guidance being very clear, and yet we seem hesitant in our region. National policies that permit non-medical providers to perform rapid diagnostic tests. We see that there are still too few countries that are willing to do that. It's usually not tied up with laws. It's usually tied up with government bureaucracies and protocols about who can test and who can't. Now, a third recommendation that I would really like to encourage is we need to review our laws, policies, and practices, including the issue of age of consent. And here are a number of countries, Laos, PDR, Marshall Islands, PNG, Vietnam, Cambodia, Austria, other countries that have revised their age of consent laws so that young people can access services. Why is that so important? Take a look at this slide. This is from Indonesia. These are HIV infection rates among men who have sex with men in Indonesia, and it goes back to 2007, 2011, 2015. Take a look at that. Among other things, it indicates so clearly that for at least the last 10 years, men who have sex with men in Indonesia get infected as young men. And if we wait until they're the legal age of consent, or if we wait until they're 25 and have the maturity to talk about sensitive issues, you can see we're missing the vast majority of our opportunities for HIV prevention. Young people are sexually active, and we need to make sure that the laws, policies, and practices are reaching them. Now, I want to recommend a fourth policy recommendation, which is super easy in this group, because we've talked about it already and it's been articulated so well. But that is PrEP. Today's guidelines from the WHO, and I'm just reading now from the 2015 and 16, is that this is not limited to specific populations. We need to make PrEP available. And there should be no question today about what is the evidence and the guidelines from WHO and the world experience. And yet, when we take a look in our region, only 4 out of 8 countries that are priority countries for the HIV response have actually introduced PrEP. And they're almost always boutique, small pilot projects yet. So what's the deal here? We've made a commitment to 2030. We've made a commitment to 2020. We know that PrEP works, and we have WHO guidelines that say these are our global recommendations, and yet we're only 4 out of 8 countries are actually moving that way. Here's an example again from Vietnam. Among the men who have sex with men, 91 say they would like to access PrEP. And in fact, Vietnam is one of those countries that is doing pilot testing. Fifth and final recommendation, and I don't want to go over time. A fifth and final recommendation is we know that the guidelines today are test and treat, or as we heard so beautifully today, same-day ART start. And yet, we still see a few countries in our region, including a country like India, which is the pharmaceutical cornucopia of the world for ARVs, still having restrictions on those who can access treatment based on their CD4 count. In our region, this is the second to the last slide, in our region, our 90-90-90 is more like 64-66-29. Only 64%, 2 out of every 3 people know their HIV status. Out of those 64%, 66% are accessing treatment, and 30% are able to demonstrate a viral load suppression. So we've got enormous challenges ahead. If you look at Asia and the Pacific, this is that CD4 count of when people are accessing treatment. We have seen progress in this region, but in fact, just look at that. Our region has some of the latest attenders in the treatment because we're putting up barriers for people to access their testing status and enter into treatment. So as good public health professionals, as activists, as people who want to make a change for good in the world, what do we want to do on that? Just have that in our data banks and in our PowerPoints? Or do we really want to act on that and say, wow, we can do better than that? I think that's the challenge, and I guess that's what I'd like to end with, is that if we're going to change this scenario, which today is only 1 out of 3 people are accessing treatment and having immune suppressed levels. If we want to change that, I would argue we need to really take a look at harm reduction, community testing and self-testing. We need to take a look at our legal policy reforms, including age of consent. We need to expand PrEP today, and we need to make sure that we're moving forward on same-day ART start. Thank you very much.
Thank you very much, Steve, for that, helping us to think about how we can end AIDS in the region. And the next speaker that we have, Professor Diane Havlir, is going to give us an example of an innovative approach that she's been and her team have been leading in Africa to try to achieve these goals. You heard her give the memorial lecture this morning, and it says on the program, Chief of HIV at San Francisco General Hospital. Some of you may not know that the hospital went through a name change. It's now the Priscilla Chan Mark Zuckerberg San Francisco General Hospital. But when I brought this up to Diane after it happened, oh my goodness, Facebook just bought the General, she pointed out very quickly to me, don't forget the Chan, because Priscilla Chan is the brains of that family, and she's a trained pediatrician. And so we're very happy to have you come and speak to us about the SURGE program.
Great. Thank you very much. So my disclosure for this talk is I am not an expert in this region. You all are. Steve clearly is. But just a little bit of context for this brief talk that I'm going to give. I always tell people when they think about going into HIV, do not go into HIV if you don't like change, because things change every single year. And don't go into HIV if you don't like targets, because we have targets and we hold ourselves accountable to those. So what I'm going to share with you now in the next 10-15 minutes or so, I work, as you know, in San Francisco. I live there, and I'm happy during the discussion to answer any questions about how we did our Getting to Zero in San Francisco. Professor Andrew did a really nice job talking about New South Wales. We have a lot of similarities in San Francisco. So, but this talk is going to be another place where I have worked for over a decade, which is in East Africa. And we have an ongoing project where we have achieved 90-90-90 within 2 years. So what I'm going to do is to share with you how we did that, not because it's going to directly apply of what you're going to do in this region, but hopefully stimulate you to innovate. Like I have actually been stimulated to innovate in different ways after listening to some of the talks this morning. So that's a long-winded introduction to this, but I wanted to give you a little bit of context. So what I will do is talk briefly about our study, which is called SEARCH, and then talk about one way to get to the first 90 and what can be gained, and then how we exceeded 90-90 targets after 2 years, looking through the lens of the overall population, gender, and by age, and then a brief summary. So the SEARCH study is an ongoing randomized test and treat combination prevention study, and it is being conducted in Uganda and in Kenya in the rural regions. This study is fully enrolled. It has over 330,000 individuals, and it's going into its third year of follow-up. This study is looking at a multi-disease population-based streamlined care strategy for the intervention arms, and that's a mouthful, but I do want to explain how and why we took a multi-disease approach in terms of moving towards HIV elimination. So the first 90. So we just heard in the last talk from Steve, and actually from multiple speakers, we'll never reach the first 90 unless we bring testing into the community outside of the health facility. That is not to say the yields in the health facility are naturally going to be higher, but as we reach more and more people, the yield in the community is going to be greater. And one of the things, at least in our study that we've learned, is that focusing on community health, not just HIV testing, has been an effective way to mobilize people who are at risk for HIV. And building on the talk that I gave this morning, we should never think of HIV testing in isolation. We should think about collapsing the cascade and linking or starting care at the testing site. And during my streaming video interview with Professor Prapan, he asked me a really great question was, do we need to have doctors are the ones to start the starter packs in the field, or can we have community health workers? And I would agree with Professor Prapan that we should be training our community health workers to do that. And that is a further, more efficient way to streamline the cascade. So when we were looking at how are we going to find 90% of people in the SEARCH study in order to make them aware of their HIV status, we looked at all of the literature, we reviewed all the barriers, and these are very familiar to everyone sitting in this audience. Lack of awareness of HIV risk, stigma associated with HIV testing, cost to the client, and perceived benefit. So at least in our geographic region, this was a testing feature in how we approached this. So we did massive community and peer education. In terms of stigma, instead of putting up a big sign and say this is HIV testing, we are approaching HIV elimination through improving the whole health of the community. And I believe it was, I think it was Benjamin who talked about it in his talk this morning, which I really love this, is that it's the responsibility of the whole community for us to move towards HIV elimination, not just people who have HIV or who are at risk. And by putting HIV in the context of multiple diseases, whatever it is that the people who are your clients would be interested in, that helps reduce the stigma. So the cost to the client to get testing, what we did is that we took a health fair approach and that we reduced the travel costs by making these health fairs close to individuals. We made it so there was rapid throughput. You'll hear, as you did in Benjamin's talk, time and time again, you need to think about the opportunity cost when we expect people to engage in healthcare. When they're at healthcare, they can't run their businesses and they can't do other things that they want to do. And then also, we've been using behavioral economics, and a real interesting thing that's come out of this, we use raffles. And at least where we're working, it's interesting, the woman and there's different prizes, there's a limit on prizes, we're not giving huge prizes. But women feel better when everyone gets a prize. For men like the high stakes prizes. So even using things that we know from our colleagues in economics to help motivate people to engage in healthcare behaviors. And then, of course, perceived benefits, HIV treatment for all other diseases. So the data I'm going to show you, I feel very comfortable with. We had the opportunity in this ongoing study to take a census of every single person that's living in this region. We actually do digital imaging or fingerprinting, which is socially acceptable. That's what's used for voting. So we know every single person that lives there, and when they go to clinic, we know who goes to clinic. So we really do know our denominators in this study. So after doing a census and going to every single household, we do a 2-week multi-disease health fair, and then if people don't go to the health fair, we do home testing for people who were unable to go to the health fair. Okay, so these are the types of things that we did in order to get people to participate in the health fairs. We made the campaigns near your workplace, weekends, and actually one of the things that was very popular, we did something called Moonlight Community Health Campaigns or health fairs. And this particularly for the occupation of the fishermen, they're always sleeping during regular clinic hours. They start their day around 6 o'clock at night. So by having this health fair at night, it really met them where they were, and that's just such a good thing to think about when you're doing community testing strategies. When we say home testing too, this is something interesting, and I'm building on the home. People don't necessarily want to get tested in their home. They want to tell us where they want us to meet them, and that's also very, very effective. And it puts the control in there just into their mind as opposed to us telling them we're going to go to their house, which could also create stigma. Other things that we did for mobilization, regular advertising, and we heard from Professor Andrews' talk just about creative things that they were doing in New South Wales, and raffles, as we said. This was interesting, some of the services, and this all came from the community. We asked the community when we designed this, besides HIV, what kinds of things would you like to have at a health fair? And actually some of the things that came up were diabetes, hypertension, we're looking at malaria endemic regions, and tuberculosis. But this was interesting. What this came up with something called a men's tent. And I'm not sure what the equivalent is here, but in the United States we have talk shows where you can call in and ask questions about sex. And so essentially this is really what the men's tent was at the health fair. It was a really safe place where men could go and ask all sorts of questions, anything they wanted to ask about sex, erectile dysfunction, how to please their partners, et cetera, et cetera. And this was a big draw to HIV testing. So this is just a visual of how we did the health fairs. We did mobilization. These are actually wedding tents that are used in East Africa that are on the shores of Lake Victoria. The community here is, we're having mobilizing events. Then people check in. We get information about their height and weight. Then we do their blood pressure. All the blood draws that we did here was from finger prick blood draws, so we didn't have to take a lot of blood. We did diabetes, hypertension testing, and then we did counseling. We did deworming for the kids and gave out bed nets. All through this whole campaign, and then for every person it took maybe 35 to 40 minutes for them to get through a community health campaign. And when we did our mobilizing activities, which were many sports, many fun relays, in order to participate in the event, you needed to go through the health fair and get all the diagnostic tests. And on site, we had people from the clinic who could meet people who had a new diagnosis of HIV, diabetes, or hypertension. And so, as I mentioned earlier in my talk, there was a warm handoff. People knew someone was going to welcome them when they came to the clinic. And then we did same-day ART start for many people who were newly HIV diagnosed. Okay, so this is what we were able to achieve with this. We achieved 90% HIV testing in adults. And of these adults, 37% were new HIV. And then among adolescents, 88% HIV testing coverage. This was super, super high. And I think this was because we talked to the community to ask them how we could mobilize the adolescents. And adolescents were going around with loudspeakers, and they were at the table and planning. A lot of times we sit and talk about adolescents, but we don't include them in the planning. And I think that that's a really, really important thing just to think about for everybody's own programs. And then we did heat maps just to show geographically where people did not know their status. Red is bad here. It means the persons living there don't know their status. And you can see after we did the campaign and after we did the home testing, we were able to get to know the HIV status of all those individuals. And then the cost of this was, in terms of costing studies, doing the health fair approach, was in line with other mobile testing approaches, and actually the marginal cost of adding, in this case, hypertension and diabetes was only $1 per person. And I'm not saying that would be appropriate here in the Asia region, but there might be other health services that could be done in a similar way. So in terms of the second and third, starting ART and staying in ART, really to summarize this, we did patient-friendly services that included all the things that patients really want. So we had same-day ART start. We had a very welcoming environment. We did all sorts of training. There can be often a very putative atmosphere sometimes in the clinics. If you don't show up, you're put at the end of the line. We just tried to change all of that. And as opposed to, I think Benjamin said in this talk, you don't blame the patient. We say, what's wrong with our systems if this person can't come to the clinic? And fostering trust, flexible clinical hours. One thing we learned about adolescents, they like to come sometimes on off hours. We had a hotline, and then one of the things we found very, very helpful was viral load counseling, which was a structured format to celebrate when there was viral load suppression and to talk about it when patients did not have viral load suppression. So now I'm just going to show you data that were presented at the International AIDS Conference. Among our 77,000 adults in the intervention part of this ongoing test and treat study that got these health fairs and this streamlined care approach. And the prevalence was about 10%. And here you can see about a third, I think, where we're going to be going with discussions, were in youth. Okay, so this is really the punchline of my talk here, that this is known HIV status. About 70% were known and the baseline of our study, and we reached 97% after 2 years. And this was using this health fair and home testing approach. In terms of individuals ever on ART, we went from 80% to 94%, and then achieving suppression, we stayed around in the 90% range. So, and we have new data we're going to be submitting to the National AIDS Conference that these targets are even higher after 3 years. Okay, so when you multiply 90, then you get a 73% population level suppression. Now, we measured this directly in our study, so we're very comfortable with these numbers. And so on a population level, we've achieved about 82% of all persons living with HIV have a viral load suppression. But that, of course, means that there's 18% who have not achieved viral load suppression. And Nydia said in her talk, and I really agree with this, you cannot assume when you achieve these targets you're going to shut down the epidemic, because it entirely depends on who these 18% of people are and what are their sexual risk behaviors. So finally, I just wanted to talk about the by gender and by age. So we started out with men on a population level, about 44%. We caught up. Women were 50%. So males were, at least in this epidemic, were behind. And then this is the really, very troubling statistic about adolescents that we defined, or youth, as 15 to 24 years of age. What you can see at the beginning, only 28% of them had virologic suppression, and by the end of our 2 years with what we did, we only achieved 66%. So this is really a big focus of where we are. So to summarize here, using this multi-disease, patient-centered, community health-based approach, we were able to exceed the 90-90-90 targets. I can tell you we have not shut down the epidemic, and right now we've re-randomized all the communities and are doing a risk-based score offering a PrEP, and I'd be happy to talk about that during the discussion if it comes up. Our population level viral load suppression increased from 45 to 84%. We still have disparities, remain large for youth, and unless we close these disparities, we are never going to get close to HIV elimination. So they remain large for youth and they exist for men that improved over time. And this is some of our ongoing work. So thank you very much.
Thank you, Diane. For those of you who came in a little late, what we're going to do is go ahead and have all 4 speakers present, and I'll invite Dr. Petchsri to come to the stage now, or to the podium now. And then after they speak, we're going to really encourage you all to come up to the microphones to ask questions. And some of this is very interesting and new data that I myself have never seen before. So hopefully this is inspiring you to think about what you will want to ask. So now it's my pleasure to introduce Dr. Petchsri, who in the program says she's a consultant for the Thai Ministry of Public Health. Consultant doesn't really cover all of the amazing things that she does. It's actually, in terms of, it's too general, because what she's done from the very early years of the HIV epidemic in Thailand is to create and implement strategies for controlling the epidemic. And her guidance and wisdom have been sought by many people here in this room and throughout the Thai government to support policy and program advancement. So Dr. Petchsri.
Good morning. So, all of you are awake, no? So, good afternoon. What I'm going to share with you here is about how Thailand make the efforts towards the ending AIDS. I will go directly. Actually, you know about Thailand, but if for those who come here for the first time, so please explore Bangkok. In Thailand, we have now we come up to be a quite rich country. We call the upper middle income country. And we have the established universal health coverage and also the health infrastructure that going down to the sub-district level, covering about around 5,000 people. For the epidemics, the new cases, the incidence is naturally declining. And in 2016, there are estimated around 400,000 people living with HIV, and the coverage is 66%. The last point I think I would like to focus here is that the behavioral, the variables among key populations in Thailand over the last 5 years, even now, is still the same and at a very high level. Like for female sex worker, condom use is up to 95%. So for this part, that I would like to show you in a timeline that how the effort, how long that we have been doing this one. Actually, the inspiration for talking about the AIDS-free generation has come up since the International AIDS Conference in 2012 in Washington, D.C. After that, in August 2012, we have the national consultation of the strategic use of ARV. As I said, we cannot just only depend on just only the behavior only. So we talk about the strategic use of ARV, and at that time we have the working groups coming up, and then the working group on the modeling of the cost benefit of treatment as prevention has come up with the investment proposal for ending AIDS at that time. So the main point is a combination prevention, but the focus, we said that we should treat people living with HIV at any CD4 level or regardless of CD4 level. And then in nearly 1 year, June 2013, the National AIDS Committee approved the proposal to end AIDS in Thailand. And that's coming up to, we have the National AIDS Strategy 2014-2016, and including this. And along this treatment as prevention, we also have a subcommittee on biomedical intervention. So that's also talking about the PrEP and as well. Even though we had the approval since 2013, but however, to start ART, we need some time, no? So the national guidelines of diagnosis and treatment and care for people living with HIV is one reference things, no? for the concerned organizations. So we have just started ART at NE64 level in October 2014. Can you say something? Mistakes here? It's January 2015. So at that time, from the national strategy, we have to come to the national operational plan accelerating ending AIDS 2015 to 2019. I would like to focus on this point that if we have just only national AIDS strategy, it's a little bit yes, no? But it's really not so concrete, no? That to be for everyone, for the funding and also for the implementation. So we have made the national plan, but this is for the part of accelerating one. So from this, we have the grants to reach key population. As Steve has said, in Thailand, the same thing for key population. And for this one, we got the resources from the Global Fund, from the USG, and right now we are moving to use a domestic resource that is from the National Health Security Office. We call 200 million projects now, something like that one. And also the Department of Disease Control. Not only that one, I think in order to move the country to end AIDS, I think it has to be done on the way of the scaling up, to have the coverage. But not only that one, but we need the, we also have the research and development. Actually it's done by this and that, but we found that it's very useful. We have the test and treat project for MSM that Dr. Nitya has presented this morning. And also we talk about the community-led health services and also PrEP. So these kind of things, I think when we are going to move on, not just only we got the policy, we got the money, but we have to know how to make it well. So this, the operational research or research and development here would be very crucial for Thailand. And not only that, monitoring system, that is also important. Otherwise, we don't know where we are. And for this one, I think the main, the issues that we in Thailand, we tried a lot is try to estimate the size of key population. And that's very important because it's come to the estimation of resources needs. So that is very important. Is estimation, we talk a lot, which method should be good. But I think it's okay, so we can move on, and then we can assess and then make it close to the reality. And also the monitoring system, we move to the era of the e-cascade. It's not and also that real-time cohort monitoring system. So it's not just only the cross-sectional one to see that things. That will not be helpful much on the implementation. So right now we move to the cohort monitoring. So this is something that we are moving on. And not only is a cohort, not just only at the end of the year, but it's the real time. So this is the point that I think we have put the effort on here. Not to the end yet, but it's on the way. I think this slide is, is popular in Thailand. Actually, it's what do you call? I think I would give the credit to UNAIDS. No? At that time, the UNAIDS country office has done this for us, but the content we work together, and we found at that time this slide has been used a lot to convey the message to all concerned parties that we can make it. Thailand can achieve not only the high-level meeting targets, but also ending AIDS in 2030. I don't know this first or that first. But however, for this one, we see that what we mean by the ending AIDS, so less than 1,000 new HIV infection per year, and elimination of mother to child transmission, of parents to child transmission of HIV. For doing that, we have to high coverage of the testing among key population, that is 90%, and also treat at any CD4 level. And I would like to share with you here that in order to convince the policy makers at that time, we got very good support from UNAIDS, from WHO, and also from TUC, that I think this slide is used and is very convincing for the people. Just only ending up the red bar there, up there, from what the country has already supported. So only that one, and then we can come up. We like this word, no? Additional $100 million invested in the next decade. We will get the benefits return 300 million. So one, and then we got three. So I think we need this, and I remember the chair of the National AIDS Committee. Oh, just only this much? Yeah, okay. So this is the summary of the efforts at the beginning. I think we make it in three components. The first one is the technical issues. No, we have to be clear. So that will be in the national guidelines. And for funding, we have to do two things. We have to do with the policy makers. So that's the National AIDS Committee. But the other, we have to work with the funding agencies, National Health Security Office, the Social Security Scheme Office. But for me, I'm thinking that the third one is very, very important. So it is about the implementation issues. National operational plan, I think, is really needed. And also talking about implementation capacity. So this is what we learn. And for this time, we always say that it's not like what we have been doing or have done before. But this time it's not only just to the control AIDS, no? But it has to be ending one. So I think this word is very powerful. And we always say that because people at that time, at the beginning, argue a lot. You are going to medicalize HIV. But we said, no. It doesn't mean that we will throw away the condom program, condom use program. It's a combination prevention. So this is something that we have to be clear at that time and use the treatment as prevention like that. To do the national operational plan, we have to make clear on the targets as a number. If 90, yeah, that's also good, no? But it's not really reflect how much that or how many that you have to do. So this is something that we have tried to make it touchable, something like that one. We have the 3-0, something like that one. So, but make it in targets like this one. I will not go into details, but for this one, I'm thinking in Thailand. I don't think that people working on HIV in Thailand will not know RRTTR. So this RRTTR is like a strategic framework for the operation. And these 5 services has to be in continuum at that, so we are working on this one, but in the future we talk about PrEP, where to put there or something like that one. And not only that one, that service, but in our national operational plan we also have as I said, the implementation capacity is crucial, so the system strengthening both for facility-based service, community-based service, is very important, very important. And not only that, we have to have the strategic information and M&E system good in place. And the last one, actually this is still something that for my personal view, I'm thinking that we are not so in good progress. That is how to normalize HIV and HIV testing. So that's the fundamental things, no, that we have to do. Otherwise we cannot reach the people enough. And from that one, in the national operational plan, we use information to understand whom we should focus and where we should focus our interventions. And this is something that we try to see, we call it targeted service package by population, by geographical areas, and we define the how to deliver services in different levels of priorities. And this is something come to the current situation in Thailand right now. This is the data in 2016. 95%, more than 90%, 70% and 81%. But the first 90, I think the important thing is what is the estimated people living in HIV number there. So this is something that need technical issues, not to how really close to the reality, the estimation here. So that is something that we have to think about. But I think those who already know, in Thailand we still have still 70% of that one. So this is something that we have to tackle here. And also 81%, we can see that not all of them get the viral tested. So I think the second and third 90 is something that we have to do now. But for the first 90, we have to go back to see how we can make the estimation close to the reality. And I would like to share with you here in 2014, 15 and 16. I don't think that, yes, the first 90, we have to go back to see the estimation. But the second 90, I think this is something, those who reach the people, they get tested and knowing already. And I think this start ART in one day may be something as a solution. But however, if you look back, and then going to see at each hospital, not so many people with HIV. So if everyone concerned on this one and then seeing, so we can recruit them into the ART treatment. So this is I cannot remember whether it's the last slide. It's the key issues towards ending AIDS from my perspective. Even I'm retired now, but maybe live as the present for those who are in this room. So the filling the gaps of 90, it can be done by both the policy level. You can put in the National AIDS Committee how many people still already diagnosed but not treated yet. So what kind of policy of the National AIDS Committee to work on this one? And then looking at for each levels, each province, each hospital, I think these kind of things has to fill the gaps. No? But the very most important point is how to sustain these targets. No? We may be like a ตื่นเต้น exciting. No? For this one, but to sustain, we have to build up the system. The community-led health services as part of the national health service system, how to make it. So this is a key issue. Normalizing HIV and HIV testing. How to make the province think that they would like to have their own provinces ending AIDS in their province. The ending AIDS is not only the national level, but it's your own areas there. So I think this is the very crucial that will maintain or sustain the 90 or coming to not only 95 but should be 100. No? And also the last part is about the real-time cohort monitoring system. So this is a key issue towards ending AIDS in Thailand. I would like to also share with you here, because when we talk about 90, we always forget for MTCT here. So everyone is happy on that moment, but I don't know whether next 2 years we are going to be smiling like that. So, so this is something that the team has thought about sustainability. I think we have to do, but mainly I think the province ownership is very crucial, no, to sustain all of this one. So thank you.
Thank you. Thank you, Dr. Petchsri. And so our last speaker is Surang Janyam, who is the director of Sex Workers and Group, or SWING Foundation, and really her commitment to her work exemplifies the slogan, "Nothing for us without us." She's been a tireless advocate for sex workers and the community, and really making sure that they have a voice and building capacity for future work in policy, research, and education. Kun Surang.
Thank you, Dr. Annette. Good afternoon, and also สวัสดีค่ะ First, I would like to thank Dr. Prapan and Dr. Nitaya who invite me to be a speaker. That is, I feel is very, very proud. That's because this area maybe is not for the committee, but you give the space for the committee to speak in this time. I'm really excited. Say by Dr. Petchsri. What I feel right now, the feeling for me right now is same as in the last 34 years ago, when I first come to be the NGO. That is my organization is working with sex workers. In that day, that is first day for me. And then my boss, she make appointment with me to meet her in the bar in the Pat Pong. Does someone know Pat Pong? Yeah, that is amazing. Not like this area. Yeah. I had to go to the Pat Pong by myself. I really excited, and the same feeling that today, but only different area. This is not Pat Pong. This is a conference area, and then that is Pat Pong, but the same feeling. Yeah. Okay, today that is what I want to present. That is the role of the community worker to implement the national effort to ending AIDS. Yeah, what I speak is not just only myself, but this is the experience from the MSM and the transgender group in Thailand that we have been working together, and then we try to come together to helping the country to ending AIDS. Sorry, maybe something wrong. Something wrong with my slide. Is this not the right slide? Not the right slide. Oh no. Okay, why don't you speak to this one? For some reason that slide is missing. I don't know. Okay, so sorry, one of Kun Surang's slides is missing. We're not sure why. I have the. Do you have the other one? Do you want to? Can we load her new slides? Go ahead. Can you go ahead? Thank you. Sorry about that. So we're going to take a few questions while we load Kun Surang's correct slides. So any questions for Steve, Diane, or Dr. Petchsri in terms of policy things that people have been thinking about, writing down on a piece of paper? Come right up to the microphone, please. And can someone come up, please, and help Ms. Surang get her appropriate slide set? Can you take your USB down to the back? Thank you. So sorry. Go ahead, please.
Thank you. My name is Pimpanita from FHI Linkages, Thailand. And my question is to Ajahn Petchsri about the technical issue. I mean, I do know that we do have national guidelines, but another puzzle that I think make a huge impact in our uptake, both PrEP and ART at any CD4 level, because we have to listen to Surang first, but we know that after the community reach the clients and then test and know the HIV positive, and the community workers take the clients to the hospital, but the big issue that we face about some of our Thai physicians are reluctant to prescribe ART at any CD4. They would suggest that, okay, wait until they have symptomatic HIV or wait until CD4 lower than 350. So how should we go over this barrier? Thank you.
Dr. Petchsri?
Hello. Hello. Actually, this issue has been discussed in among the national programs here as well, and we found that there are some like that, and they recognize that you can see the second 90 is not as much as it should be, and this is one reason. And there are some, even we have the national guidelines clearly say that you start ART at any CD4 level. But for this, doctors sometimes, physicians sometimes it's not easy. We have to make them understanding well, because for the first moment, actually Thailand we have this national guideline at any CD4 level before the WHO guidelines. So at that time, the doctors in some places, they still say that we should be less than 500. But that's not many cases, because people are still coming late. We also try to solve this problem. And I remember I heard the people from one province in the south, they said they have to ask Dr. Nitaya to go there to talk to the doctors. When we had the meeting, we had the training, doctors don't have a time to come. No? So at that province, they asked Dr. Nitaya to talk to them. So this is one small example, but I think to do this, to solve this problem, we have to understand the situation in each hospital. So this is something that I'm thinking. As I said, I would love to see the province would like to end AIDS in that province. So for this not only this problem happen, but many other things. So the province has to tackle, has to know the cause, has to know the reason. The context of each province are different. So I cannot answer that directly, but I think for this one, the key factors are physicians as well.
Okay,
I remember I got the questions from the people living with HIV. The people living with HIV, they know that they can get at any CD4 level. They try to talk to the doctors, but not successful.
So thank you very much for the question and answer. Sorry for the delay. Thank you for bearing with us. And Kun Surang is going to probably shed more light into the issue of community engagement to get people to follow guidelines.
Okay, thank you again, Dr. Annette. Now I'm coming back. Sorry, Dr. Nitaya, that it make you so exciting with me, same as before. Okay, this is what I want to say. This is the role of the committee, how we implement and to help the national to effort the ending AIDS of Thailand. If we look at in the past, the challenge was what we are faced in the past. We are follow the strategic plan that is Dr. Petchsri showed you before. That is RRTGR. That's for the role of the community. What we are in the past, most of the us that we work, what we do is, we are only reach and recruit. That is always, that's okay when we are together with the government. That's okay. We say okay, that is your role of the committee is okay. You know how to reach the people. That you have to do outreach, and then you reaching the people who are the high risk population and also the key population. And also after that, okay, can you helping the government to recruit the person who have the high risk behavior to come to get the testing, and after that, okay, for test that is the role of the government and role of the healthcare provider to do, is because we are the community people. We can do a testing that's in that time. And also after we refer our community people to get testing, if they are who are positive, the government, they will give a treatment. Yeah, they will follow the guideline to give a treatment. And then after that, the retention. This is the discontinuity that we just discussed who to take responsibility in this role. Because for the committee like us, yeah, we did not do a testing. We cannot know that we can get the result. That is yeah, we cannot get it. And then when the case that we refer them to get testing, they are positive. We don't know how to follow them, how to retention them, and that's why so many of the positive case that they lost from to get the treatment. This is the problem what we are faced in the past. And also, if we look at the result from the drop-in center that we provide the reach and recruits in the past, and then we can bring only 100 of the case with just testing or later than that. And also for the positive case, yeah, just a few number of them can get the treatment. This is a problem what we are faced for long time ago. That's when we look at the data, when we look at the result, what we are doing. Yeah, if we keep still doing like this in the future, we cannot achieve the goal what the country want to achieve. The lucky us in the last 2 years ago, in May year 2015, the test and treat project we start. The test and treat project is supported by the USAID and Petchsri. This is lead by the Thai Red Cross Professor Prapan and Dr. Nitaya, who are leading the test and treat program. We are the community-based organization who are work with MSM and the transgender in Bangkok and Pattaya and also the Chiang Mai, the north of Thailand. We get invited to join this project. In this project, the Thai Red Cross, we train the community people to do a testing by the community themselves. They train us how to do a counseling for the same day testing. They train us how to do the fingerprint and so many things that we have to get trained. And after that, the Thai Red Cross, the AIDS Resource Center, they do a QA/QI for make sure the community people like us can provide the service by ourselves. And also they will do a coaching. And for this time, we can say that we can do for the whole cascade. We can do reach and recruit. That's okay. We already have experience in the past. But right now, we can do the testing by the community. And also after that, okay, when we do a testing, we will know the result of the client who are negative or positive. If who are positive, we will helping them to support them to get the treatment for make sure that they will be on the system. And after that, for retention, that we have the question before who should take responsibility in this role. After we start to do a test and treat program, or we will come to be the community-led health service, the next I will call the CLHS. We can do the retention also. We have a care and support team who will take care of the positive case or even the negative case for make sure who are positive, they keep continue to get a treatment, and also they have a good adherence, and also if who are the negative for make sure that they will come back to do a repeat testing in the next 6 months or next 3 months or whenever they get a risk behavior. And for the improvement, what we do right now since the last 2 years ago, we can see if we look at the result, we can see more more than 1,000 of the MSM transgender in each drop-in center who can get testing. And we can see the number of more of the positive case who can get a treatment. Some of the drop-in center, they have the people who are the positive, they can get the treatment is around 80% or 60% or 70%. This is very high if we compare on before what we are doing. Just a very few number of the case who can get the treatment. That's okay. Yeah, now we can say that we are the one-stop service. We can do the first 90. We can bring the people who have the high risk to come to get testing, and then after that we can bring the people who are positive to get a treatment, and then for make sure that the keep continues to be on the treatment. What the success what we get from the community-led health service or the CLHS? Yeah, this is the big change. In the past, yeah, we are the client, the staff we bring to get a testing. But now the CLHS can transformation the role from the client. We come to be the service provider. This we are very proud because most of us we are the community people. Some of us we are the sex workers. Some of us we are the transgender. In the past, we are the client. But now when we can come to be the service provider, we are very proud because when we are in the flow of the service, we have to wear the uniform. That uniform is the what I forget. Okay, sorry. That is okay. That is the clothes. That is okay. Like a doctor. Like a doctor, it makes me feel that we are the equal with everyone, because in the past some of us we are the sex worker. But right now our act is like a doctor, like a healthcare provider. This one is we are very proud of our position right now. And the second is how the success of the CLHS. This is the trust shifting. That is mean we can sharing the burden of the work of the healthcare provider. Because I think it's everywhere, in every country we face the same problem. Because the healthcare provider, they have a lot of the care that they have to serve it. But when the CLHS are coming, that we can help so many things of the healthcare provider to serve the client, to do the service. It's one thing that we try to do the betting to achieve the goal. That is the country want to go. And also the third is CLHS, that is addition option for the key population. In the past, we have only the services provided by the government. That is not mean the service is run by the government is not so good. It's very good. It's very good. You do a very good, but only sometimes the working hour of the healthcare provider in government unit, you are open in the morning, 8 in the morning, and then you close around 2 or 3 p.m. But for the people like a sex worker, they are open in the afternoon. They are open in around 1 a.m. or 1 p.m. or 2 p.m. And then when they are wake up, the business is closed. The service is closed. When they want to get the service, the doctors go to sleep, and then we cannot meet each other. But when that is not mean the doctor sleep at the daytime, the doctor sleep at the night time, but we wake up at the night time, and then we cannot reach to the service. That's why when we have the CLHS, that's okay, we can open the service, the time that can serve the needs of the key population. And the last point that CLHS is the fulfillment in the national AIDS response. That's okay. We try to support among each other. Even we are the government, we are the committee people, we are the civil society. We try to do the best thing to support among each other to ending AIDS in the country. That is for the CLHS right now. We already have to advocate the CLHS to the national and the policy level. We hope that the government, they will accept the idea of the CLHS and then they will expand to another area, or maybe in some of the country we get this idea to can use this model to expand in your country. We believe that the CLHS would be one of the strategy to help to achieve the 1990 targets, because if we follow the strategic framework in Thailand, we can do RRTTR, what I explained you before, for reaching. We know where and how to reach our friend, and we know and how to reach the key affected population, because we are the same committee. And also we know who have the high risk behavior, and then when we can identify them, and then we can bring them to get testing, and then we can do a testing. If they cannot come to get a testing in center in our clinic, we can move to meet them in the club, in the bar, or in the sauna, wherever they are. We can move our service to follow them to make sure that they can access to the service, and also for treat also. Under the test and treat projects, we can provide ART in our drop-in center in our clinic, because we have the doctor from the Thai Red Cross, we have the doctor from the hospital where we are on the network. They come to provide the service in our drop-in center. But for some of them who are not be a part of the test and treat program, we can refer them to get treatment in the hospital where we have a networking, and then for make sure everyone to get a treatment. And for retention, that I told you before. For positive case, that we have the process how to helping them to get a treatment. But for who are negative, yes, we have another option, PrEP. PrEP, that is another the option that for someone who know that they cannot control the partner to use a condom. PrEP, that is another option for them for protect themselves. That is on the retention process. We are the support that we are need to achieve the 1990. The enhance of the capacity building that we are still need. Even right now, there are some of us, we can provide the service by ourselves, but we still need to get more capacity building. We still need to learn more about the new technology, like Dr. Nitya presented this morning about the online testing and self-testing. That's something like that we want to learn, something that is the new technology. We want to improve our quality of the service, what we done. We don't want to do the same thing, because if we do the same thing, we know we will get the same result. And then that is so far away that we can achieve the goal that we want to achieve. And also, that is what we need is right now for CL community-led health service. That is We have only 7 of the drop-in center in 4 of the province that we can provide the community-led health service. We need the support to expand more community-led health service in another province, in another area, or in another target population. That's because we confirm that is if we let the community people, they run the service by themselves for their community. That is very helpful, and that is very success what we see in the past. And the last issue that we heard a lot about the differentiated care. Right now, if we want to see the doctor, maybe we have to spend for whole day to waiting the queue to see the doctor, or we have to spend for a long time. That's why many of of the people don't want to go to see the doctor. Even they are on ARV, when their ARV finished, they don't want to go to see the doctor because many of them they cannot get a holiday in that day to meet a doctor. I think the CLHS, that is the one of the strategy can help the healthcare provider to work on the case who are stable. Because if for some of them they are very healthy and then they need just only the ART refill, maybe they don't need to go to see the doctor and wait for whole day, but they can go to the community-led health service and then they can get the ART. This issue maybe we have to discuss, and then, but we cannot wait for a long time. If we wait for a long time, I think there are so many people will get lost from the service. And the 3 policy recommendations for the CLHS that we need is the accreditation. That is really important. The accreditation, this is like to confirm the quality of the service of the CLHS. We need like so many guidelines and the SOP for confirm the service is run by the committee that it have the high quality as the service is run by the government. In the second issue, that the legalization. Right now, the service of the community-led health service, what we done right now, we are under the umbrella of the Thai Red Cross. This is like the pilot project and research project, what someone said before. We wondering what happened if this project is finished. Who will protect us? Who will protect us? We need like a very strong support from the government. Just review the policy and the law that you can do. Can accept the service is run by the committee people to be a part of the national system as same as the service is run by the government. It's the last point is the financing. Most of the work for the committee right now, the funding came from the outside the country. That is not a sustainability. We're talking about how can we sustain if we don't have the budget to support us. CLHS cannot continue if we don't have the budget to support. This is one of the main issues that we have to focus. The last slide. I would like to say that the community-led health service is not about the competing with the government service. It is not we try to steal the role of the healthcare service, but we try to filling the gap that we are faced for a long time, and then everyone want to go to the same goal. We want to achieve the same goal. That's why. But the CLHS that we try to bring the people together. We try to join together. Even we are the government and we are the committee people, and then we can work together to ending AIDS and to achieve 90-90. Thank you.
Thank you. Thank you, Kun Surang. If you could just give me 2 minutes. I know we sort of blew our question time through various things. Sorry about that. But to summarize what we've just heard today, in terms of trying to figure out how we can end AIDS in the region, we heard from Steve Kraus first give us some very interesting, totally up-to-date data from the AIDS Data Hub, which is a website if you want to go there to find out more information, that we're not doing as well as sub-Saharan Africa. 1 in 3 people having access to treatment. And we're falling behind. We're not rising up in terms of the numbers of people tested, infections prevented, and yet we've seen through Diane Havlir's presentation on the SEARCH program in Uganda that this is possible. Not even reaching 90-90-90, but exceeding that, except for in certain kinds of populations. The data of 66% compared to 84% of young people are suppressed. Even though they were able to test over almost 78,000 people, they have really nice health fairs. Under wedding tents, they have incentives and raffles, and despite all of that, fingerprints, still only 2/3 of young people less than 25 were suppressed. So there is a problem there that we are all facing around the world, and we need to figure out how to address. But Dr. Petchsri pointed out how Thailand is really grappling with this and is seeking to end AIDS by 2030. And there are committed champions in this room and in the Thai government who want to see that happen. So year after year, if you come back to the Bangkok Symposium, hopefully you will see progress towards that. And the elimination of mother-to-child transmission was a major goal that they were able to achieve. And then finally, Kun Surang, sorry about the problems with the audio-visual, but Kun Surang emphasized to us that we need community-led partnerships. That is how Bangkok in particular, but Thailand now more broadly, is achieving these goals. But it can only be achieved if we, all of us doctor people and provider people in the room, if we follow the guidelines, as was asked earlier. If we are not prescribing medicines to our patients, even though the guidelines say so, if we are not prescribing PrEP, even though our patients are eligible, we're not going to make it there, because slow and steady is not going to get us to even where Africa has achieved. So we thank you very much, and thanks to our speakers for a wonderful panel. And for those of you who had questions and wrote them down and got ready, please feel free to come up to the stage, because our speakers will be here and ready to answer them. Thank you very much for staying late. Thank you.
Nice.
Oh, I'm sorry.